begin our meeting this afternoon. Call the meeting to order, and the first person that we're going to hear from is Dr. Fitzgerald over the Department of Public Health. Dr. Fitzgerald.
Thank you so much. We are delighted to be here. And for fiscal year 2016, as you can see, our budget consists of 63% federal funds, 33% state funds. The changes proposed in the governor's budget this year. First are the statewide changes, which include a merit-based pay adjustment that is statewide, and then 2 increased funds for the employee retirement system. For the statewide changes with administrative monies, the first is a decrease of $92,000, and that is because of a decreased liability the cost for us, and a slight increase in PeopleSoft, which is our TeamWorks billing. The increases are listed as one. The governor recommended that we have $132,000, and that is for personnel services. There are about 100 people in our agency who do not have salaries that are at the minimal level for their pay grade. So this is an adjustment to bring those folks into a normal pay range. And then the important one for us is that fifth-year phase-in for general grant and aid formula. As you all know, this is the money that goes directly to the counties, and the governor has recommended $1.4 million for that. The next slide, the next presentation, these are all the programs. None of our programs have changed, but this is the breakout where those monies go. There is one additional request, and those are general obligation bonds. This total amount is $10 million, and if the number in the tracking sheet is 50.2.3.39 for the big one, and that's the Clinical Billing Information Technology System. As you know, we have had 18 different IT systems throughout our districts, which means our districts have had trouble exchanging information, and we have also had some trouble with billing. This is critical for us because as the federal funds continue to decrease for payment for patient services, it is very, very important that we get the IT support necessary we have to make sure that we are able to do adequate billing. The other 2 items are, again, for our state lab in Decatur, and they both have to do with cooler and chiller systems for the lab itself. The next bit of information I want to talk about is you gave us $490,000 last year to begin autism work. And this is the report of what we have done with those monies. The important points for autism is the diagnosis needs to be early, and the interactions need to be global, meaning that we absolutely need to make sure that we bring parents in and we train parents to help with autism. This is important because if you look at early diagnosis, and this was a study done in about $1998, $33,000 invested early in a child with autism results in over a $200,000 savings later on in that child's life. So it's an important part financially, and it's an important part, as we've learned from the MARCA system, to make sure that we change the trajectory of these children's lives. So with the money, our goals were, 1, to increase early identification and screening, because that's when you can make the difference, and that's when you can invest most wisely. And second, to provide that family support training for the families to help them with their autistic children. We have hired an autism program manager. We did that with federal funds to oversee this program, because this program is one of the priorities in our department. If you look, what we have done is we have targeted in the family section, the early intervention and family support, 150 families, 150 children who are in our Babies Can't Wait program, and we are teaching them with the Marcus tools on how to be supportive with their children, because it's important to have the resources to treat professionally, but that's not enough. Those children need recurrent, constant interaction, and this is the program that teaches those families how to do that. In the next section, the early identification and screening, we have trained 125 people in the public health department on early diagnosis. And the second part in diagnosis, we have trained 25 psychologists in each of these target districts. And the notion is that we will concentrate both early diagnosis and family instruction in these counties and see if that collaborative effort can be of help for these children. The next, you see a map, and these are the districts that are involved. The next monies that you gave us that I want to tell you what we've done with that money is hepatitis C money. This was $85,000 that you put in our budget. We are thankful for that, by the way. We know that there are monies in the Medicaid budget for treatment. I understand it's $23 million approximately for treatment. Our piece of the puzzle is to provide the analysis and the data. One, to get those tests, to encourage testing, and to get those tests recorded in a place where we can help identify for the state where the problem is occurring, what the contacts are. Our part is a data piece. So with that $85,000, we have hired a data manager to manage this hepatitis C data for us, and also we have hired two and have posted one other data entry person to actually get the test in a document for us. That way we will know prevalence in the state and we will know location in the state so that we can aim our efforts. The other money that you gave us last year is the Alzheimer's Registry, and this was $110,000. What our notion was, as we worked with the Alzheimer's task force, we found that there was really no source where we could get reliable data. We could not really, we could give estimates, but we really couldn't pin down exactly where patients are, exactly how many we have, and exactly their ages and their comorbidities, what are the problems they had. And that, of course, is important for us, again, as we are planning how to approach this problem. This is the diagram for what we have come up with. Our notion was there are lots of places where data exists. And the bottom three, the hospitalizations, emergency room visits, and vital records, that's information that we already have. So if you look then on the ones in light orange, those are the agencies that we have approached for their data. And then where you see the darker orangish brown, the patient data, that is a new point of information that we have added. We are working on a system where doctors can enter electronically information into our whole data information system. And then our epidemiologist in public health will take all that information, sort it, make sure that that there's no doubling of entries, for example, and come up with some analytical work on the incidence in Georgia and exactly where folks are and what they need. For example, let me tell you, like in the Medicare portion, we have some preliminary data, but it hasn't all been put in and cleaned up. But the Medicare data, we know that there are 93,000 people, a little over 93,000 people in Georgia on Medicare with a diagnosis of Alzheimer's. For Medicaid, we know there are 7.3 thousand people in Georgia with a diagnosis. And from Georgia Regents, we know there are 433. We don't have preliminary information from the state data plan yet, but again, we are beginning to get the data, but it is not the point yet where we would recommend it for usability. But the web portal is going to be active beginning in March, the 1st of March, so I think we have made real progress. The Medicare data, we have applied for, and we hope to get that. It usually takes 4 to 6 months for us to get it. We've applied for it, so when we get it, we will hopefully this time next year be able to give you more accurate information so that will help in your planning. The next slide this is the list of our key initiatives, which we have talked to you about before, and we'd like to give you a little update in 4 of them. First, childhood obesity. As you know, we started in Georgia that we had the 2nd highest incidence of childhood obesity in the country. And as you thankfully passed the SHAPE Act that required fitness grams done for every single child in Georgia where they are having PE. So these are the results from this year. We did, again, over 1 million students this year that were tested. 71% of them, of all students were tested. Of those children, again, 40% were not in a healthy fitness zone, and 22% of our children could not pass one single part of the fitness test. And again, as I've said to you before, that's talking about not being able to walk a mile and touch your toes. So again, we are very concerned about that, and we're also concerned, quite frankly, that the incidence for young girls was higher than for young men. So we are wanting to aim some of our efforts towards solving that problem. The Governor's Council on the SHAPE initiative is doing well. We had a super meeting in September with over 150 people from academia, from research, from medicine. That went very, very well. One of the things I want to tell you about, you know about our program about Power Up, and that is the plan to have 30 minutes increased activity every day, every school, every child in Georgia. This is the analysis of the Macon schools. They have had that in place for 1 whole year now. And again, remember, there are 453 schools who have agreed to do this, but Macon has actually had it in place for 1 year, and they had 63.7% of their students improved aerobic capacity. That's the most important one. That's the one that's most important for health. That's the one that's most important for learning. They also, by the way, had an improvement in their weight. Their total weight went up, so that was good. But the most important thing is the aerobic capacity. We also have one other test that has been done this past year, and that was in the Cobb school system. And what they did is they matched in their school those children that were in the healthy fitness zone for aerobic capacity, and as you can see, they had higher. The blue is the kids that had the highest aerobic capacity, were in the healthy zone. They had higher scores in math and reading, they had fewer discipline problems, and they had better attendance. So we know this works. We know we should do it, and here's the part I need your help with. This is the map of Georgia. Those counties in orange do not have any programs at all. We do have the over 400 schools participating, but that means about twice as many, 800 and so, are not yet. So again, we ask your help in putting pressure on your hometown schools. If they are not participating, please do so. It's good for the kids' bodies, it's good for the kids' minds, and it's good for our education system. The next update I want to give you is our infant mortality work. And you may have heard this information before. We for decades have been in America's health rankings. We have been in the low 40s, in the 40s of the state of the 50 states. And in 2012, we were ranked 44th. The next year, 34th, and this year, 31. And so that's good because we certainly have had cooperative public-private efforts to do that. We've made real progress in prematurity. And again, the total decrease in our numbers has been exceptional. Not only are we making progress as far as other states, but we're making real progress. This year, I've got to tell you, one of the things that I am disappointed in is the safe sleep numbers. The third cause of infant mortality in this state, first is prematurity. We've made progress there. The second is genetic defects. That is unchanged. And then the third is safe sleep. So we really are going to this year be concentrating on that part. The third part, I think we've mentioned this to you last year, and this is the whole business of early brain development. And I think I told you last year that the difference between children who can learn and who develop language and children who do not is 30 million words difference by the end of the third year of life. Those children who are talked to get actual brain development. So these are our WIC posters. We have trained 196 WIC clinics. Over all of our nutritionists are trained. We are halfway through our first year, and in August we will do an evaluation of that program. I think I may have told you last year that when we did the evaluation of the children in our WIC clinic, they were at the 40th percentile of word recognition, but only the 10th percentile of word comprehension. So this program in WIC, we have posters, we have videos running constantly in the waiting rooms. They sit down with a nutritionist every 3 months. The nutritionist gives them information about the importance of talking to their babies, and they go home with a book. So we are pleased about that, and we hope there will be progress. The other thing I want to give you a report on is Telehealth Network. It is now completed, as we told you last year it would be. This is important in our mind because of especially rural access. We have been looking at some data comparing rural health and non-rural health, and sort of as a global number, the age-adjusted death rate, and that means, you know, when you're 97, you may be expected to die, but we age-adjust it. But the rural death rate per 1,000 is 899 compared to the same age people, 783 in non-rural. So that whole business about access to rural health is extremely important to us. And we have ability to access care in all counties now. And this next slide, these are some of the things, these are some of the first projects, but again, we are open to collaboration with, it's not like we have the docs, we're not the medical system, but we do have the ability for the people in rural communities to go to the health department and access people throughout the state, and we are very pleased with that. One last thing I want to do, of course, we're the infectious disease people, and here are the updates on the two things that may be on your mind as far as infectious disease. At this point, we have monitored 755 patients, travelers who are from Ebola-infected areas. We are doing this electronically. It is going very smoothly. We have tested 5 of those travelers for Ebola. They have all been negative. We have evaluated 19 of them at our various clinics. That is all going smoothly and very efficiently. I am so proud of our medical community for the response to this. The next is the measles update. I can tell you that we indeed do have the first measles case in Georgia. There's important things that you should know. This is the first case we've had since 2012. We had 2 cases in 2012, and the previous before that was 1 case in 2010. So we have sent out from Public Health information to docs, alerting them because lots of young docs have never seen a measles case. And this case in Georgia, we have begun the evaluation of contacts. It was a legal immigrant from Kyrgyzstan, and there were about 230 people who were exposed, some on the plane flying over, and there's legs of the journey that CDC is evaluating. We're evaluating the last leg of the journey that was from Chicago to Atlanta. In those folks that we've evaluated, 35 of them were at risk so far. We are still completing that, but 35 were at risk so far, meaning they were too young to be vaccinated. There was one, for example, baby in arms on the plane, and that baby has been given gamma globulin. The rest of the 35, we've either given vaccinations. You can give vaccinations within 2 days. You can give gamma globulin within 6 days. So Thursday, tomorrow is the last day, but that is going very, very well and very, very smoothly. Our basic immunization rate for measles in Georgia is 98.3%. So that's our children who are in elementary school. The data says that if you have 95% of your kids vaccinated, you probably are not going to get a widespread outbreak. So I'm very pleased that Georgia's children are basically immunized, but certainly we're going to do everything we can to make sure that the immunization rates are as high as humanly possible. So with that, sir, if there are any questions, I'll be glad to take them.
Okay, thank you, Dr. Fitzgerald. Do we have questions from the members? Anybody? Yeah. Try that.
Thank you, Mr. Chairman. I'm really interested in the autism initiative and applaud you for getting federal money to appoint a program. The counties, how were the counties chosen where the educational efforts are being initiated?
Well, the counties were chosen because we wanted some rural counties, we wanted some urban counties, and they really were just chosen for our pilots because we sort of wanted to get a feel on how we could do it in the rural areas, how in North Georgia, South Georgia. So as you can see from the map, there's North Georgia, there's South Georgia, and there's Central Georgia. And so we just chose them basically. Back one more, Kate. We just there it is. We just chose them as places in the state. They were not chosen because of high incidence or anything like that.
And this is in coordination with the Marcus Center?
Absolutely.
I noticed another piece is the PBIS. Did the federal grants for positive behavior intervention come to your department or to the Department of Education?
It's not ours. It must be education. It's not ours.
So this is on the State Autism Initiative, the Early Intervention and Family Support?
The early interventionists are our workers in the health departments who do Babies Can't Wait.
Okay.
So those are our workers who do work for high-risk children. That money does come to us, the high-risk children money.
I know there's an initiative in the Department of Education and in some school systems, so is there coordination with? Right.
Kate was saying our part is the preschool and the older children are in the, so our really part, we consider our part that first 3 years of life. Yeah. That's where we're going to concentrate before they get to preschool. We have we have not done the direct linkage yet with the autism piece. We are just beginning to do that work. I can tell you we are a little bit further along in the language work with deaf and hard of hearing children. Mm-hmm. And it's the same notion. We have children in that very earliest, that 0 to 3 population, and then DECAL has influence, and then DOE has influence. So we have begun very actively in that, and that would be a good model to use in this autism work too. But we have not done that yet.
Thank you.
You're welcome. Representative Quick has a question for you.
We have not done that. I can tell you this. The medications for hepatitis C, as far as being able to cure hepatitis C, are a little bit newer on the scene. But we do know that if you look at the cost for liver transplants, because that is, if you look at the people who require liver transplants, there's a huge number of those that are absolutely directly related to hepatitis C. So we can do that cost analysis for you, but we have not done that at this point. Yeah, I'm sorry.
We didn't get any new money in 16, but the 85's in the base.
Okay, well, that leads to my next question. You referenced the on average per person.
It's very expensive.
I know the program is very new, but how successful do you anticipate it being identifying, saving 2 cases?
I think the success of the drugs is very good. I mean, we have had. We'll be glad. We have our infectious disease leader is Greg Felstein, and he's an infectious disease person. He's actually our employee that does that is over our HIV work, because we do HIV treatment and hepatitis. I'll be glad to have him come and sit down with you and give you that data. Treat and prevent.
Well, prevent, catch people who may not otherwise know.
Yes. 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 Yeah. And Kate was reminding me, one of the things that our piece, that $85,000, of course, is not enough for us to go out and do mass screening. I mean, it's just not enough. So, but what we see as our piece with that money is to indicate prevalence, to say, like I think we have shown you, for example, if we can show you where the cases are in Waycross and in what populations, then we think we can do more targeted approach to screening those different populations. We don't have that data yet.
Other questions? Dr. Fitzgerald, let me ask you a couple of questions. I know your department has been sort of stressed and taxed with the task of dealing with Ebola, and now with the measles that we're reading about, and now we have our first case here in Georgia. Do you feel like that we're adequately prepared from your department's needs and so forth to make sure that you're able to carry out that mission?
Yes, sir. I believe we're prepared for Ebola. I do know that we need to keep our epidemiology section strong. And I think I would be remiss to say that we certainly appreciate the support you all have given us in the past for general public health work, and we hope that you continue to support us with our needs because we have those professionals that aren't anyplace else, like the epidemiologist.
Okay. And then one other thing, would you explain to me how teledentistry works?
Well, yes, sir, I'll be glad to. Mostly it's a screening tool, and it has been very successful in the Waycross area, and we take the carts into the schools, and kids are delighted. There's my teeth on TV. And then we partner with a local dentist and make sure those children who have problems found during the evaluation of when our nurses go out are seen. So teledentistry is not like you're across the room and you fill a cavity. It's more like like it's a screening process. And interestingly enough, the numbers off the top of my head, I think that we found in the school district in Waycross, I believe it was they found 60% of the children in a couple of the school districts that really needed to be referred for dental care. Yes, and Kate's reminded me the number one absence in the schools for absence from school is dental problems. So if you go into those, especially again those rural communities, and what's been nice about that program is we can refer then those kids, wherever they need to go.
So really, it's a screening that
Yes,
you do, and then work with the dentist if there's one in the area.
Absolutely.
That we find it'll see 'em.
Absolutely.
Okay. Any other questions or comments? Representative Gardner, you?
In terms of the grants to counties, I noticed it's the 5th year phase-in of the hold harmless for counties like Fulton County who
Yes.
lost in the
Yes.
formulating.
Yes.
Is this the final year?
We hope not.
Me too.
2 more years. We hope there are 2 more years. When we had looked at that original phase-in, we had hoped that there would be a 7-year phase-in. I mean, we sort of looked, because that gives the counties that, of course, had increasing population a steady increase and holds those counties that are losing significance. So if it's this year, if that indeed is approved, that we would be very grateful for that, and we'd be very grateful if there are 2 more years of that.
Thank you.
Okay. Any other questions? Dr.
Thank
Fitzgerald,
you.
thank you very much. Appreciate that.
Thank you for all your support.
Thank you. Okay, next on our agenda, the Georgia Brain and Spinal Injury Trust Fund Commission, Craig Young. Ready? Okay, we're ready when you are.
All right. Chairman Parrish, thank you. Members of the committee, thank you. We would like to give a brief presentation to the committee, and that will include our FY 2016 appropriations request. As you may know, the commission was created by constitutional amendment by the citizens of Georgia in 1998. During the November general election, nearly 70% of Georgia voters approved an additional surcharge upon conviction for reckless driving to be remitted to the commission. The commission is grateful to you and your fellow legislators for approving the proposed amendment, and grateful to the governor and the people of Georgia for their support and trust. The House Budget Office has estimated that revenue from this new surcharge would be approximately $250,000 annually. These funds will augment the Commission's budget, which has steadily declined over the last 7 years, as you will see presently. You're good. Yeah. So the mission of the Trust Fund is to improve the quality of life of Georgians with traumatic brain and spinal cord injuries by distributing funds and resources and making policy recommendations to enhance statewide infrastructure. We're governed by 16 commissioners, 10 of whom are selected by the governor. 6 are appointed by other state agencies. We are administratively attached to the Department of Public Health, but have separate funds and budgets. Next slide. By statute, we have 3 programmatic areas. We distribute funds to Georgians with traumatic brain and spinal cord injury. We contact recently injured Georgians and generate demographic and statistical data on injury via the Central Registry Database for Traumatic Injury, which is an unfunded mandate, and we advise stakeholders on policy regarding TBI and SCI. How the commission is funded, a 10% surcharge on DUI fines, and of course, beginning January 1st, a new surcharge on reckless driving. DUI collections have declined 30% since fiscal year 2008. We also have supplemental funds. Recently, DHS remitted $452,000 in unappropriated funds to the commission, which was old debt. We also can amend in funds to supplement our current year's distribution. Our FY 2016 appropriation request, which is page 69 on your budget tracking sheet, section 37. As you can see, our FY 15 budget was $1,784,064. Our FY 2016 surcharge collections and budget is $1,449,027. That is a decrease of $335,000 in our budget. The next slide, as you can see, DUI surcharges, our top line, the red line shows how our revenue has declined since 2004. And the red line and purple line, state courts and municipal courts are the primary sources of income, and you can see since 2008 how those remittances have declined as well. Next slide. Of course, the reason for the decline in remittances is the decline in DUI convictions. So you can see that from 41,000 in 2008 to 31,000 in fiscal year 13, we are steadily seeing a steady decline in DUI convictions. Driving under the influence of drugs or alcohol is a significant public health threat. Reckless driving is also responsible for many deaths and life-altering injuries. DUI fines can, of course, be reduced to a lesser charge, such as reckless driving or other non-driving offenses. Next one. The need is great. If you look at our injury data from 2009, you can see the number of traumatic brain injuries at 72,000. It has increased to 75,000 through 2012. Individuals who are seen in a hospital, emergency department, or are actually admitted to a hospital are collected. That information is collected from the Georgia Hospital Association. The Commission assists those injured Georgians with individual grants for injury-related expenses such as vehicle modifications, assistive technology, attendant care, etc. We also contact those recently injured. Last year we sent 20,000 letters to those injured. Unfortunately, due to our budget decreases, we've had to eliminate organizational grants for information and referral, TBI camp, and other services. We've also had to eliminate direct on-site outreach to regional hospitals, rehab centers, support groups, and independent living groups. Next one. Since the Commission began awarding grants in 2002, we've awarded 4,738 grants with a value of $20 million to your constituencies. And in FY 2014, last year, the trust fund awarded grants worth $1.5 million to 210 applicants. And again, those applicants would have asked us for goods and services that increase self-sufficiency and keep an individual out of an institutional setting. Some examples would be attendant care, wheelchairs, home modifications, environmental control units, vehicle modifications, therapies such as physical therapy, speech therapy, vision therapy, cognitive rehabilitation, memory training, and much more. FY15 key facts. Our monthly award budget is now $95,000 per month. That's a 23% drop from the FY13 figure of $117,000 a month. We will amend in $204,000 of previously appropriated funds to help increase the monthly distributions we make to our applicants. Currently, we have a waiting list of 43, which is about a 2.5-month delay in funding, and the average number of days from an application submission to completion is 69 days. We collaborate with a number of other state agencies and organizations, including Community Affairs, Public Health, DHS, DCH, Public Safety, Education, Governor's Office of Highway Safety, and Voc Rehab, and of course other health-related organizations such as the Brain Injury Association of Georgia, the Shepherd Center, Children's Healthcare of Atlanta, Centers for Independent Living, and the Georgia Hospital Association. And I'll be happy to field any questions that you may have.
Good, thank you. Any questions from the members? Okay. Craig, let me ask you a question. You had said there were like 43 on your list waiting. What kind of money would it take to take care of that waiting list so that you didn't have a wait like that?
Let's see. I'm going to guess about 3. It's going to be between $300,000 and $400,000.
300, between 300 and 400, because you'd have different people with different needs. And
that's correct. Some people may wish to get a modified van, which we could make a grant for $15,000. Other people might need a computer, which is $750.
Right. Okay. Thank you. Any other comments or questions from the committee? Thank you very much.
Thank you.
300, 400,000. Okay, next and last on our agenda is the Georgia Trauma Care Network Commission, Dr. Ashley.
Good afternoon, Chairman. All right. We'll pull it up here. Okay. Do y'all have the copy of the handout? Or are you just looking at the slides? Okay. It's okay if you don't have the handout. I can't see your monitors. Can you see the slides from there? So, okay. Well, I'll wait for you to get the handout then. The slides go right with the handout. Okay, again, I'll run through this very quickly. As you see on the second page of the handout is the super speeder law. This is our revenue funding source and our only funding source for the Georgia Trauma Commission, which is to develop the statewide trauma system. If you turn the page, which is slide 3 or page 3, you see the revenues that are generated from the super speeder law for the years that it's been in existence. You see that we're staying right at about $20 million in 14, 15, and the projections for 16 are the same. You see our budget was $15.3 million. Last year you all increased that to $16.3, and we're very appreciative. We would certainly like to see an increase this year up to the funding or revenue stream, which would be $20 million. The reason that's important, if you'll turn the page 4, you see these are the readiness costs for the level 1 and level 2 trauma centers. And you see the fiscal years listed on the left. And if you'll go all the way to the bottom where it's fiscal year 2016, you can see our proposed budget of $16.3 million. And if you look over to the right, you'll see the cost for the 1 and 2 trauma centers are $66 million. If you look just to the right of that, you see we fund about $4.6 million or 7 cents on the dollar. Readiness costs are the costs that are incurred by the trauma centers before they ever see the first patient. This is the cost of having neurosurgeons, orthopedic surgeons, trauma surgeons, plastic surgeons, OR availability, and a lot of other things ready to go 365, 24 hours a day. So it's considerable cost there that you see, and we only cover about 7 cents on the dollar for that. If you turn the page to page 5, you can see these are the uncompensated care costs. And again, going all the way to the bottom, fiscal year 2015, you can see there was about 3,000 patients statewide that qualified for uncompensated care as defined in Senate Bill 60. That's been holding steady about low 30s, $32, $35 million a year in uncompensated care costs. We are able to reimburse only about $5 million of that, or 15 cents on the dollar. If you turn the next page, page 6, this is the budget proposed for this year. You see it's broken down, $11.7 million for the trauma centers and physicians, $2.6 million for EMS stakeholders, about $800,000 for system development, access, and accountability. I'll talk more about that in just a second. About $490,000 for Department of Public Health, the Office of EMS and Trauma, who does the actual designation of the trauma centers and the regulation. Commission operations listed there, and then finally $150,000, which is basically seed money for the Georgia Trauma Foundation. We've received IRS approval in June, and the foundation is now up and going. We were supposed to do that as part of SB 60, develop a foundation, and we've been able to do that. And the goal of that foundation will be education and research and prevention for trauma, and will allow the commission to reach out into the private sector and ask for additional funding through the foundation. If you go to page 7, again, looking specifically at trauma centers and physicians, what's that money for? Again, it's for readiness costs. Again, it's only 7 cents on the dollar. And of that money, the commission breaks that down into 50% the centers get up front, but the other 50% is performance-based payment. We have deliverables that we expect them to meet, quality measures, and once those are met, the centers can get the rest of their readiness cost funding. It covers uncompensated care, trauma registry software. We're going to do another readiness cost report this year. We do that about every 3 years to make sure we stay on top of accurate data. And the uncompensated care claims audits, which are done. If you turn the page to page 8, you can see what we've been able to accomplish over the last several years. As far as the number of trauma centers, one of our jobs were to increase the number of trauma centers, and you see in year 2009, we added a level 2 trauma center, Athens Regional Hospital in their region as a level 2. In fiscal year 2011, Atlanta Medical Center and Eggleston upgraded from level 2 centers to level 1. And we added another level 2 center as Wellstar Kennestone. In 2013, our 2 burn centers became certified by the American Burn Association and received their formal trauma center and burn designation. In 2014, we were able to add another level 2 trauma center in Northeast Georgia, which met a huge need in that area, as that was the only trauma center in that area. And you see in 15, 16, we set aside funding, even though we really don't have the funds, but it was a tough decision for the commission. We elected to slice the pie even a little bit smaller if need be, to bring on an additional level 2 trauma center in South Georgia if that is possible. Turning the page to page 9, we have enough data now that we've put a little bit of science into the picture of who needs to be a trauma center and where do they need to be. Using some pretty sophisticated modeling that we've learned from some of our colleagues in Florida, we've been able to look at all hospitals in Georgia and the severity of their patients, their trauma patients, and we've identified, based on geography as well as volume of trauma, a sort of a top 5 or top 10 list, if you will, of centers that would be proposed that we would welcome into the system as they would meet a great need. And you see them listed there. I'm happy to say that the first one listed there, Northeast Georgia, did come on as a trauma center, and they are functioning now, so that but again, it's a voluntary system, and all we can do is offer, but that offer still stands. If you turn to the next page, page 10, EMS stakeholder funding. A couple of things I'd like to point out here. The first line, Automatic Vehicle Locator System, or the AVLS system. This is basically a hotspot in the ambulance that allows state agencies such as GEMA, if there were a mass disaster and they needed to know where all the ambulances were at one time, they could flip a switch and basically be able to see that on a screen and know where all the resources were. From a daily standpoint, it allows the ambulances to have hotspots where they can send information on heart attack patients such as EKGs and things of that nature straight from the ambulance right into the hospital. The thing that's important about this is that Georgia is actually one of the leaders in the country for this particular technology. A lot of states have this technology in scattered parts of the state. Developing regional trauma advisory EMS regions committee. And the reason for this is we want them to write a plan for their particular region, because what will not work in South Georgia or North Georgia. Each region needs to have their own plan. But again, that was tied into a state plan. And I'm happy to say that most of the regions now, out of the 10, 4 have functioning plans. Another 2 or 3 are developing those plans, and the rest have started to form their committee. We're actually ahead of pace on that. We thought that would be a 2 or 3 year project, but with the support of OEMS&T and Department of Public Health, we've been able to make great strides there. The reason that's important is because it says direct funding to regional trauma advisory committees. Based on input from the folks in the local regions, we can get a feel for their needs and understand what their resources need to be, and they can apply to the commission for funding. And that's what happened in Region 1. They had a lot of tornadoes in that area one year. They all pulled together and said, we need to have a sort of an emergency plan so that we can deal with this, and we need some funding to get that started. The commission was very impressed with their presentation, and we are funding that. Again, there's a different need in Region 4. They want to look into telemedicine directly from the ambulance, and we're supporting that project. So by developing these committees, we have the ability to reach really into the local areas and find out what the needs are of the EMS community or the trauma community and try to fund those. The next page, page 11, system development and access. I really talked a little bit about that on the previous slide when I talked about the 10 EMS regions and the regional trauma committees, so I won't go over that again. As far as our system, we're also working with rural hospitals, providing training to physicians and nurses on really how to identify the critically ill patient and transport those patients to the trauma center quickly. You see the acronym TQIP there, Trauma Quality Improvement Program. Georgia, this is another perk for Georgia, as we're only the second state to actually have this statewide. Michigan has it, Georgia, and the other states are really trying to implement it. There's a lot of states that have scattered trauma centers here and there, but we're the only state that has this registry to where we analyze our data on all the trauma centers. So every level 1 and every level 2 trauma center has this outcomes measure. And I'm happy to say that we've been recognized at the national level through the American College of Surgeons and the TQIP program. And Georgia has presented at that conference the last 3 years, along with Texas and Michigan, and are helping them develop and write the state reports because our state has all their trauma centers on that system. As far as the Georgia Medical Reserve Corporation, Dr. John Harvey, working with the Medical Association of Georgia, approached us about disasters. And in areas of the state, there's always plenty of physician volunteers to go to wherever the disaster is, but they show up without a badge. They show up and they're not credentialed, and there's really a limited availability of what they can do. So this is a program that will credential volunteer physicians, provide them with badges, get them credentialed in all hospitals so that if they show up for a disaster, they can hit the ground running, and this is really a sort of a pioneer program, if you will. The resource availability to screen leads into the next page, and if you'll turn the next page to page 12, you see what that shows with all the colors. If you remember, I think when I reported last year, over the last couple of years, we've had a trauma communication center in Forsyth, Georgia, that fielded calls 24/7 to help EMS and hospitals direct their patients and find the appropriate trauma center to take the trauma patient to that was open and ready for business. At the end of that pilot project, we analyzed all the data, and what we heard from EMS and hospitals was that they really didn't need a call-in center. What they needed was this screen. And so they liked the idea. You see the trauma centers listed to the left, and at the top of the screen, you see all the resources. It's in small print, but basically what it says is orthopedic team, trauma team, ICU, and so on. And if you have a green jelly bean, that means you have that resource. If you have a red one, it doesn't. You're on diversion. A yellow one means there's caution. You're approaching a full capacity, and black means that you've never had that service. And so what we heard from EMS is that they would really like to have this in their dispatch center. So we've made this available now in an iCloud or web format, where with a password, every EMS service, every dispatch center, every ambulance can have this at their fingertips. Every hospital ER can have it, so that and GEMA has access to this, so we always know what our resources are in the state. The nice thing about this, and what makes it different from other software that's available, is that we update this 3 times a day. Every 8 hours it's updated, so we know that this is accurate, and it's very useful for the healthcare providers. Working again, the next page, page 13, we've reached out to rural hospitals, really all hospitals that are non-trauma centers, and tried to provide them with some information on who do you need to transfer. And we've put together this poster this is the second edition of the poster. The first one has already gone out, but this will replace that one. And basically, it's some listings from the American College of Surgeons on who to transfer. So this can be posted in their ER to help them identify emergent trauma patients that need immediate transport. And these have been sent out to all hospitals throughout the state. And it's endorsed by all the trauma centers and all the trauma medical directors. The next page, page 14, this just tells you a little bit more about the Georgia Trauma Foundation that I mentioned earlier. I won't read all the objectives, but one of the main objectives right in the middle of the page there is to develop a research advisory board, develop a research grant funds, and really attack the cutting edge of trauma care, work with education, work with prevention. And 3 of our commission members you see are the board currently. We're going to expand that to 9 members and really go into the private sector and try to achieve additional funding to support our trauma system. As I come down the home stretch here, if you turn to page 15, I'll sort of wrap up and give you a summary of what we did and where we're going. This is the map. I told you where the trauma centers were that we added in the last few years, but this is the map of Georgia with a 50-mile radius or circle around each trauma center. And you can see those blue circles pretty much cover the northern part of the state, the central part of the state. And if you look up there at the top right-hand corner, you can see Northeast Georgia Medical Center in a strategic location. That was a big find for us as we were able to get them to come on and fill a gap. Right below them, you see Athens Regional, and right across you see Kennestone, which filled a gap between Floyd and the Grady and Atlanta Medical Center healthcare systems. So we've really, I think, covered the northern and central part of the state pretty well. You can see there's still that gap in South Georgia, but we've identified hospitals that see a significant number of trauma patients that we would like to have them come into the system. So have we increased the number of trauma centers? Yes. Do we still have a gap? Yes, and we know where it is. If you turn the page to 16, you can see, and again, I showed you this last year, but it was preliminary data. This has been vetted now, and it's gone through the process. You see from 2003 all the way to 2012, looking specifically at critically injured patients. This is critically injured patients that have a chance of dying of 15%. Okay, so pretty sick. If you look at the blue line, you can see that it was pretty flat, running about 64% from 2003 to 2009. And that means that only 60% of our patients that were critically injured were getting to trauma centers. But since 2009, really when you all really got involved with substantial, sustainable funding and with the education process from OMS&T and from the Commission, you can see that we've gone in the blue line from 63% to 84%. So a 21% increase in critically injured patients going to trauma centers. If you look at the red line for children, we're up around 97 or 98%. So we've made big strides in the last few years of increasing the number of trauma centers and getting patients that are sick to those trauma centers. So if you turn the page to page 17, does it make a difference? What's your return on investment? Do Georgia trauma centers save lives? Again, we analyzed all the data in Georgia in trauma centers and non-trauma centers looking at critically injured patients. And what this shows you, you see the red line and the blue dotted line. And you can see that the red line is always above the blue line there for least critical, intermediate critical, and most critical, meaning there's an increase in 10% or a 10% increase in probability of survival for patients when they go to a designated trauma center for the same injuries versus a non-trauma center. We've known this nationally for years. This is not new data, but it's the first data out of Georgia as we've analyzed our system. I had the opportunity to present this. This was accepted for presentation at the American Association for the Surgery of Trauma, which is our largest national trauma meeting. It's been peer-reviewed, and it will be published really any month now. It's been accepted for publication in the Journal of Trauma, again, bringing notoriety to the Georgia trauma system that we are saving lives. I will provide reprints to all the legislators when that comes out. Again, it should be within the next, I hope, couple of months. The next page is page 18. It's how about getting patients discharged home? Here I've changed the colors of the lines, I guess just to confuse you, but here trauma centers are in blue, the non-trauma centers are in red, and this is the probability of normal discharge. So when patients go to trauma centers, they have a more probability of being discharged home versus to rehab or versus nursing homes. So why is that important other than good patient care? As legislators, that's important because if they have to go to nursing homes or to long periods in rehab, they're not able to go home, and they're Medicaid patients, then that's increased funding for Medicare dollars or Medicaid dollars. If we can get those patients home, then that funding can go for other disease processes. So what's the final, not the final, this will always be a work in progress, but what's the next phase that we're looking at? Is time, the next page, time from injury to definitive care. We know that we're getting patients to trauma centers. We're doing a much better job. We know that once they get there, they have a 10% increase in survival. Now the question is, how fast are we getting them there? If it's taking us 10 or 12 hours to get them there, then that's too slow. We don't know the answer to that yet, but we're starting to look at that data or collect that data, and I hope to be able to give you an answer on that soon. The final slide, or next to the final slide on page 20, is the development of the state plan. All this has come together. You see in March, Dr. Pat O'Neill developed with Renee Morgan the state trauma plan. This was presented to the commission and was approved in March of 2014. And now Georgia has a well-organized, definitive state trauma plan that's tying into all the regional plans. And then finally, I'll end with the last slide, which is one of our Georgia trauma patients. I like to end with that slide always because after a lot of boring numbers, that's really why we're all here. I'll stop there. You've been very kind to listen to my presentation, and I'll be happy to answer any questions.
Thank you, Dr. Ash, for some good information. Do we have some questions or comments from the members? I've got just maybe a couple of questions for you, Doc. What would you consider to be your largest need to help you move your trauma system along?
I think our largest need is basically, you saw that 7 cents on the dollar. You know, I think the partnership here, you know, this needs to be a private sector, i.e. healthcare providers, and the state working together. I think that needs to be a 50-50 split. So I think 93% from the trauma centers and 7%, you know, from the state. I think that's out of balance. I think we need to improve that. Why is that important? Number one, to make sure the centers that we have stay open and have their readiness costs. Where that helps us in the next level is that you saw all the creative things we're doing with the RAD, with the organization. You saw what we're doing, the creative things in EMS. These folks in the regions are starting to realize, hey, we have a need in the region. We want to apply the commission and get approval for funding. People are starting to think outside the box now and come up with some creative ideas. It's very hard to fund these expansions when we're really sort of tied to just keeping the centers open that we have and providing basic EMS care. So I think, and again, this is not me, this is the folks that do this every day, the hospitals, the EMS providers that are saying we're going to stay in this game at 7 cents on the dollar in hopes of more funding. But at some point I worry that goodwill will run out. So my number one goals would be preserve what we have. Number two, let's go to the next level. We're being recognized nationally with the work that we're done. We've got to have funding to stay there. And we need to get some of those hospitals in South Georgia. Again, right now there's really not funding for them. You know, do we go to 6 cents on the dollar, 5 cents on the dollar to bring on new centers? That's where we're sort of meeting a quandary, if you will.
Okay. Well, along that line, I'm looking at the map here, and of course, if you are in the metro area, you're well covered, but really, if you get down below I-20, unless you happen to be in Savannah or maybe in Thomasville, you're kind of out there where there's not very much, and some of us live out there. And I guess one of the questions I'd like to find out about is what can we do other than, like you said, I know money's the answer to a lot of these questions, but like over the summer we had this hospital stabilization committee that's been working, and I think one of the things that they had been looking at was better use of the EMS and the telemedicine, if you will, and this sort of thing to try to take care of some of these areas where they're not that close to a trauma center or something. Have y'all been involved in that?
I haven't been involved with that particular committee or that program. I've heard a little bit about it. I think it's much needed, you know, that kind of discussion. What I've asked Courtney Terwilliger, who's the chair of our EMS subcommittee, to look at, and we're putting some money, EMS money, into that to what do we need to do with EMS? What are the needs? You can't have a trauma center on every corner, and there's going to be areas that we just don't have trauma centers. So what role can EMS play, and how do we redesign EMS in the sense to make sure the patients can get access? And so they're going to start looking at that at the subcommittee level and hopefully bring some recommendations.
Well, along that line, is that sort of the key maybe to some of these areas where we don't have trauma centers? And like you said, we're not going to be able to have one on every corner. We understand that. But to have a better relationship or better training or better working relationship between the EMS and the trauma centers and that sort of thing, is that what we're going to need to do in these areas that are not covered by these blue circles?
Yes, sir. And even regional planning in those areas, because those folks in those different regions know what they need. So what they need to do, as you mentioned, EMS working with trauma centers, EMS needs to also work with EMS. So we need to be creative and think outside the box. How does this county work with this county to mesh resources together to get that patient to the trauma center? Because frequently what happens is that, you know, I just talk about trauma, but these folks you can see in South Georgia, if they need to take a patient to a trauma center, that's a long drive.
Right.
So then you talk about, well, maybe we'll use the helicopter, and that's a possibility. But then again, that's just one piece of the pie. That's just trauma. What about cardiac? You know, people with heart attacks now, we're really stressing EMS in the sense that we want them to get our trauma patients to the trauma center quickly. the gentleman that's having the heart attack is just as important. He wants to get to the trauma center, or, well, the cardiac center, usually in a trauma center, but not always, wants to get to the cardiac center very quickly. Some counties may only have 1 or 2 ambulances. And then now we've got the stroke patient that wants to get access to high-level care to where they can get their arteries open and diminish that functional outcome of stroke or decreased outcome. So we're really squeezing EMS, and we've got to be more creative with how these services work together at a local level to cover and help each other. So that really needs to be looked at. You're right.
Well, do you feel pretty good about the relationship between your organization and the EMS as far as the working relationship? How is that working out?
I think so. Right now, we're working on some contracts, and Mr. Terwilliger and I, worked today on that. That's about to get finished, and so we have a very good working relationship as far as we just have some nuts and bolts issue about getting the contracts done.
But it
now.
seems like that could be one of the possible answers to some of this area where we don't have the coverage, is being able to get those people transported appropriately and quickly to the centers where they can be treated.
Yeah.
Okay.
And just as a follow-up, in that contract, Mr. Terwilliger has requested from the subcommittees, not just him, it's the EMS subcommittee that's made up of all 10 regions. They've requested some funding in their distribution to actually study and look at some of those issues.
Good. We had a question. I think Representative Quick, you had a question.
Yes, sir, Mr. Chairman, thank you, and thank you for your presentation. And I'll just say thank you.
Is that right,
I
Jim?
can bring that to you. I can get that.
That'd be great. And my question is, how much do you know is owed as of December 31st, 2000? Have they claims that the auditors found?
Let me ask
You
that
want-
one more time.
Yes. In the auditor's reports, they go through claims.
Owed to the EMS providers?
No, owed from them for claims.
If,
This grant program improper.
if the claims did not meet criteria, those were audited. If the claims did not meet criteria, they were not paid. Absolutely.
Some of the audits we do for hospitals and EMS is when they turn in their numbers, we check them, and then sometimes, like especially for uncompensated care for hospitals, we make sure they follow the rules in SB 60, and sometimes we have to kick out some patients that may be really indigent but don't qualify because they're not in the specific rules of SB 60. So we do the same thing for EMS.
We are no longer doing the EMS uncompensated care program.
That's being rolled into equipment grants that the EMS subcommittee voted on, and what that means is that every ambulance can apply for those grants, or every company, or however you want to call it, EMS service, I guess is the appropriate terminology. And they're all available, and so that's all rolled together now. And as far as the website, I'll take absolutely zero credit for that. Mr. Pettyjohn here, our executive director, keeps that website up, so it is a nice site. Anything we can do to help you, just let me know and we'll get you more information.
Well, Dr. Ash, thank you for a good report, a lot of good information, and we appreciate the good job y'all are doing, and it certainly looks like you've made some progress over the last few years with this. Thank you.
Thank you. We appreciate it.
That concludes our agenda for today. Let me remind you that on Tuesday at 2 o'clock in this room, we'll have a meeting for public comment. If anybody that wants to come and make a public comment, you'll need to sign up. We have a sign-up sheet in room 245. So if you would go by and sign up if you have an interest in speaking to the committee next Tuesday at 2 o'clock. We'll be glad to see you. Thank you all for coming.